Greetings to everyone. I am JINKA of 2x6 Founding from Pharmacology Institute of Pharmaceutical Sciences. I will be your host for today's seminar. Today we are here to delve into the fascinating topic on histamine and antihistamines. Throughout the seminar, we will discuss on various aspects of histamine like its actions, its receptors, its pharmacological actions and pathophysiological roles, and antihistaminics with their actions. So, without further ado, let's embark into the journey of knowledge about histamines and antihistamines. Prior discussing about the histamine, let's discuss a bit about chemical messengers. Chemical messengers are also called the signaling molecules, which are the substances used for regulating the many physiological processes and help maintaining the homeostasis. These carry information from one set of the cells to the other. These include both hormones and the neurotransmitters. When we talk about the histamine, it is a biogenic amine which is also called the tissue amine that is present ubiquitously in all the animals and plant tissues. Histamine acts as a neurotransmitter in the central nervous system and as a local hormone which is also called the autocoid in the peripheral tissues. It is a main mediator in the hypersensitivity reactions and also tissue injury reactions. Well, we will discuss about its roles and pharmacological actions later on. Now we will discuss about the synthesis of histamine. Histamine is synthesized by amino acid histidine by a process called the decarboxylation to form histamine with the help of an enzyme histidine decarboxylase. As we all know, the process of decarboxylation is the removal of CO2 group from the carbon chain. Histidine loses its CO2 group and gets synthesized into the histamine. The released histamine should be stored in one part of the other, right? So for this, the histamine uses non-mast cell and mast cell storages. Coming to the mast cell histamine, it is stored, major amount of the histamine is stored in the granules of the mast cell, which is present in the skin, gastric mucosa, liver, lungs and the placenta. When we are discussing about the non-mast cell histamine, it is stored in the specialized cells called the histaminocytes, which are present in the tissues of brain, gastric mucosa, epidermis and the growing regions. The turnover of the mast cell histamine is slow as well as the non-mast cell histamine is faster. It is also located in other sites like blood, which is mainly in the basophil cells, and body secretions like breast milk, bile and the semen. It is also present in the venome and the pathological fluids. Coming to the degradation of the histamine, it requires majorly of two enzymes, that is diamine oxidase, that is shortly called the DAO, and histamine and methyl transferase. First, the histamine gets converted into the amidazoles acetaldehyde by the action of diamine oxidase, which is also called the histaminase enzyme, by the process of oxidation. Next, it can be degraded into N-methylhistamine by the process of histamine and methyl transferase by the process of methylation, which is further degraded into N-methylamidazole acetic acid by the action of monoamino oxidase. Let's discuss some more about the histaminic receptors. These are the four receptors which are all G-protein coupled receptors. They are mainly H1 receptors, H2, H3 and H4 receptors. As the action of H1 and H4 receptors are almost similar, we do not discuss much about the H4 receptors here. Coming to the H4 receptors, it is a GS protein coupled receptor which is mainly located on the smooth muscle, uterus, smooth muscles of uterus, intestine and the airways, also endothelial cells and the brain, which is predominantly present on the postsynaptic neuron. 2-methylhistamine, 2-pyridylamine are the two major agonists for the H1 receptors, which undergoes PIP2 hydrolysis by phospholipase C through a process pathway called the IP3 DAM pathway. It also releases nitric oxide, which increases the cyclic GAMP concentration in the cells. It also helps in the release of the calcium from the intracellular stores. Coming to the H2 receptor, it is a GS protein coupled receptor which is mainly located on the gastric glands, blood vessels, postsynaptic neurons of the brain and the heart. It is mainly dimiprid and 4-methylhistamine are the two major agonists which activates the H2 receptors. It also stimulates the adrenaline cyclase activation, which causes the increasing concentration of cyclic AMP that activates specific protein synthesis and also causes the secretion of gastric acid, that is hydrochloric acid. When these secretion increases, it may lead to the peptic ulcer, which is treated by the H2 antagonists like cimetidine and ranitidine. Coming to the H3 receptors, these are the GI protein coupled receptors which are located mainly on the ileum, spleen and brain, predominantly on the presynaptic neurons. Alpha-methylhistamine is a major agonist for H3 receptors which restricts the calcium influx and reduces the concentration of cyclic AMP. Now entering into the major part, that is pharmacological actions of the histamine. It acts on blood vessels, heart, glands and other areas for showing its pharmacological actions. Let's first discuss about the blood vessels. Histamine causes marked dilatation of the blood vessels like arterioles, venules and the capillaries. The action of the histamine varies on its routes of administration. For example, if it is given as a SC injection, that is subcutaneous injection, it causes flushing and heats up the area where it was administered. And it also increases the heart rate and cardiac output with little or no fall in BP. When it is given through the rapid IV injection, it causes a fall in BP and also shows the early short-lasting H1 response and more persistent H2 response. And coming to the intradermal injection, it elicits a triple response, which is the combination of red spot, wale and flare. Red spot is caused by intense capillary dilation and wale, which is caused by the excavation of the fluid in the arterioles and the venules. Flare, which is caused by the arteriolar dilatation. The only H1 component manifests because of its higher affinity for the low doses. The vasodilation caused by the H1 receptor is through the indirect pathway by the activation of endothelial dependent relaxant factor, that is the EDRF, which is the nitric oxide. And the vasodilation caused by the H2 receptor is by the direct action of the contraction of vascular smooth muscle. Larger arteries gets constricted by the H1 receptors at higher doses. And coming to the heart, the in situ effects are not prominent, but the isolated effects on the heart, for example in the guineatics, can be seen as a positive inotropic effect, which refers to the increased conduction of the heart, and positive chronotropic effect, which is the increased heart rate that is mediated by the H2 receptor. And H1 receptor also mediates the negative chronotropic effect, which refers to the reduced contractility of the heart. Next, coming to the visceral smooth muscle. Histamine causes bronchoconstriction, which is highly sensitive for the asthmatic patients. The smooth muscle gets contracted by the H1 receptors, and in few instances, H2-mediated relaxation can be occurred in human bronchi. At the toxic doses, it may also cause the abdominal cramps and colics because of the increased intestinal contractility. Coming to the glands, it causes increased gastric secretion by activating the H2 receptor, in which the mechanism we can see in the later video. Coming to the sensory nerve endings, histamine stimulates the sensory nerve endings to cause itching when it is given through an IV or the intracutaneous administration, and we also recognize pain when it is deeply injected and higher concentrations. Coming to the autonomic ganglia and the adrenal medulla, the stimulation of the autonomic ganglia and release of the adrenal medulla causes secondary raise in the blood pressure. Coming to the CNS, the histamine do not cross the blood-brain barrier, so the central effects are not prominent. But when it is injected through the intracerebroventricular pathway, it produces some effects like the raise in BP, cardiac stimulation, behavioral aerosol, the gastric secretion, which is mediated by the H2 receptors. It involves majorly three receptors, that is, vagus nerve innervates the action on the acetylcholine, which activates the gastric to act on the histamine receptors. Thus, the histamine recognizes its action and acts on the parietal cells to release increased cyclic AMP that further increases the action of H+K+ATPase pump, which is also called the membrane proton pump. This increases the H+ ions released into the gastric lumen, and on the other hand, chloride shift also takes place in exchange of the bicarbonate ions, which are formed by the reaction of water and carbon dioxide, which is mediated by the carbonic anhydrase enzyme. Thus, the H+ and Cl- ions gets united in the gastric lumen to form HCl. Thus, hydrochloric acid is produced in the gastric lumen by the release of histamine. Increased HCl secretions causes the peptic ulcers. Next, coming to the histamine as a transmitter. It causes the sensation of pain and itching. Non-mast cell histaminic receptors present in the brain causes wakefulness and suppresses the hunger, which is mediated by the H1 agonist. The H1 antagonist used for this owe to the sedation and also promotes the appetite. And the H2 and H3 receptors, which are present in the postsynaptic neuron and the presynaptic neurons respectively, causes cardiovascular function, regulates body temperature and also thirst. Coming to the tissue growth and the repair, the major amount of the histamine is present in the regenerating and growing regions of the body. So it helps in the repair and growth of the body organs. Coming to the antihistaminics, which is the last topic of this seminar. These are the pharmaceutical class of drugs that act to treat the histamine-mediated reactions. There are majorly three types of antagonists based on their receptors: H1 antagonist, H2 antagonist, and H3 antagonist. Well, we discussed a lot about the H1 antagonist in this video. H1 antagonist consists of two generations of drugs, first generation and the second generation. First generation of the H1 antagonist also acts as the inverse agonist, and the H2 and the second generation drugs are now used for low sedating or no sedating activity. Coming to the H1 antagonists, these are classified based on its sedative property as highly sedatives, moderately sedatives, and mild sedatives. The examples of the highly sedative drugs are diphenhydramine and promethazine, which also acts as the alpha blocker. And the moderately sedative drugs are phenylamine, cyproheptadine, and cinnarizine are the moderately sedative drugs. And the mild sedatives are chlorpheniramine and trimastine. Coming to the pharmacological actions of the H1 antagonist, its main action is the antagonism of the histamine. It blocks mainly the H1 receptors, which also blocks the activities of the H1 receptors, like it blocks constriction of the intestine, and it also do not show the triple response, which is a combination of red spot, wear, and swelling. It also helps in falling BP, which is caused at the low doses of histamine, and it also requires additional H2 antagonists for complete blockade of the falling BP. The construction of the larger blood vessels, which is caused by the H1 receptors, will also get antagonized by this H1 antagonist. Coming to the anti-allergic reactions, it manifests the hypersensitivity reactions. The manifestations of the hypersensitivity reactions caused by the histamine are suppressed, and it also controls the urticaria, itching, angioedema, and anaphylactic reactions caused by the histamine. Coming to the CNS, the older antagonist causes CNS depression. It depends on the stimulation of the receptors and its ability to cross the blood-brain barrier, and the individual susceptibility also plays a major role in its activity. It causes restlessness and insomnia in some individuals, and at toxic doses it causes excitement and the convulsions. Coming to the anticholinergic actions, it antagonizes the acetylcholine, and the local anesthetics. Some drugs like phenethylamine, promethazine, and diphenhydramine shows a strong membrane stabilizing property, but this is not suitable for the clinical use because of its property of irritation. And coming to the second generation, antagonists. It causes absence of the CNS depressant property, and it is a highly H1 selective drug.